Good evening, everyone. This is Chad Perman from the Program Management Office, joined by my colleagues here. Today's topic is going to be social determinants of health, and then we'll go into a little bit about where we are in the program and documents, make sure we're all up to speed. Thank you all for joining today. We realize you have busy schedules and the holiday season is upon us. It's almost December. It's hard to believe, but as you know, that also means that we have about 30 days until the program starts. So we want to continue the momentum and make sure that everyone has what they need. And we also are starting to prepare for the requirements in the program, including the social needs aspect. So as all of you know, this is more than just a medical model, and we know to take care of patients, we really need to start to address needs beyond the healthcare system. So just a little refresher here. Most of the dollars in healthcare right now are spent in the bucket in blue there that says clinical care, but we know that only about 20% of that actually affects outcomes and improving outcomes for patients. What we want to do is we want to expand that focus to the other areas, to health behaviors, social and economic factors, and the physical environment. Some of this is beyond the capabilities and the province of the practice, but much of this can be impacted because of the trusted relationship that you have with patients. So the more that we can drive focus on social needs and needs beyond the healthcare system, the better outcomes we're going to get. So how does this fit into the primary care program? As you know, there are 5 advanced primary care functions. The third one is comprehensiveness and coordination. So are you providing the majority of services needed to keep your patients healthy? So that's where it fits in. In track 2 of comprehensiveness and coordination, there is a care requirement for facilitating access to community resources and supports for patient social needs. So what does that mean? And what are the requirements? The requirements are initially on the track 2 practices, but we want to make sure that all practices are thinking about this and beginning to implement, if they haven't already done this, including track 1 practices. So for track 2 practices, they are required to complete an assessment of their attributed beneficiaries' health-related social needs. And so that's the minimum. You may find that it makes more sense to be assessing the needs of all of your patients in your practice. At the same time, as many of you said before, it doesn't help if we just screen for those needs. We have to be able to do something with that. Otherwise, what would be the purpose of it? So the other part of this is conducting an inventory of resources and supports that are in your community that will help address those needs, and having access to that in a real way to actively refer or get patients into those supports. Track 2 practices are also encouraged to utilize the tool that CMS has put out called the Accountable Health Communities Model Screening Tool. It's a standardized and evidence-based tool that they've built and made available. In track 1, practices, as I said, are not required to do this, but we very much are encouraging that they begin to implement a process for screening as well as making those referrals. If you're partnering with a CTO, the CTO is likely to be able to help you address some of these social needs for patients. So the interdisciplinary care management team that a CTO would provide might help you with the actual screening. It might help you with when you do your risk stratification, including thinking about and using social needs data that you may already have in your system and your EHR to help identify who is in need of those care management resources. The CTO could also refer beneficiaries to the community social service organization. So it might make sense to have the CTO care management personnel that are working with you actually help lead some of this work, as long as it's at the direction of the provider in the practice. The other part of this, and all of you are familiar with this, is that as part of the CTO concept and scope of work, doing the screening doesn't have to happen in the office. It could happen out in the community. particularly if they're community health workers or other home visit care personnel that are being employed by the CTO to do the screening out in the circumstances of the patient's home or somewhere out in the community. There are, as I mentioned, a plethora of tools out there, and some of you may already have a tool that you like, but we wanted to make sure you're aware of other tools that are out there that could be used for this. So one is the CMS Accountable Health Communities tool. The link is provided here. It has 10 questions, and it can either be self-administered or it could be administered by someone in the practice, whether they're clinical or non-clinical. And like I said, it could be done in the practice or out in the community. The American Academy of Family Physicians has a nice tool that has 11 questions, and the link is here. There's a toolkit and a tool called Prepare. It's largely been designed for community health centers, but again, this might be a tool that you want to take all or parts of for your practice. And we also want to call out that if you'd like to see some of the tools that are out there beyond just these, there's a comparison table that we think is pretty well done by University of California, San Francisco, by a site where they have a lot of information on incorporating social needs and addressing them within the primary care setting, and that's the Siren comparison. So we talked a little bit about the tools that you would use for screening beneficiaries. It's also then once you screen, as we talked about, you would need a directory of resources. This could be self-collated and built by the practice. You may have some of this already in your EHR, or you may want to identify the resources and then have it directly available in your EHR. You could use another method. It's up to the practice in terms of the method they think that will be most effective for them. There are a few other resources that we're highlighting here. Again, not endorsing any of these, but these are some of the ones that we're aware of. So there's United Way 211 in Maryland. And Bertha has a free tool out there. And then there's a tool from the Maryland Department of Health that lists resources by county called the Maryland Access Point, or MAP. And as I said, these are just potential options, maybe to incorporate with information that you already have. You certainly could develop your own directory and have a process that you would refer patients and make sure that you're getting information back on whether their needs are being addressed. Just a reminder how this fits in, there are payment incentives specifically for social needs in the program. The care management fee is meant to address all of the care transformation requirements. So you can be using the care management fee to hire staff to develop a process for screening in the office or in the community. And within the performance incentive payment, as we talked about, the ED and hospitalization rates are impacted by social needs. We know that a person's circumstances, their social needs impact their utilization rate. So I think it's important to remember that as you understand the relationship and the impact that it has on the payment to the practice. So long term for MDPCP, we are developing some more tools. We also think that there are potential workflow changes that practices can incorporate if they haven't done already. So the data and tools that are listed here, these are not ready today, but these are things that we are working on and hope to have ready in the next year or so. So we'd like to have an enterprise screening tool that would be available as well as a resource directory for around the state. We are working on developing something like that. It would not necessarily be required for use, but it would be something that would be made available to practices and potentially make this easier for them. There's also, in terms of social needs data, we're working on whether there's additional data that we could provide and make available at a zip code or census level that could be included in the CRISP reports. And in terms of risk stratification, there is work that's beginning on developing a predictive risk and risk stratification tool that would be made available to practices, and that would include social data in it to understand what is the real risk score for the beneficiary. On the workflow change side, practices can incorporate knowledge and social data certainly into stratification, as I just talked about. We think an untapped resource is doing the annual wellness visits for Medicare beneficiaries, and within that, performing a health risk assessment, which is going to capture much of that social data. And the annual wellness visit, as you know, is a good source of a payment to primary care practices as well. Other things like demographic data, assessment of health status, psychosocial and activities of daily living, those are the kind of things you probably want to be thinking about in terms of tracking, making sure you know what that looks like so you can have a more robust screening method. At this point, I am going to hand off the presentation to Dr. Haft.
Thank you, Chad, for that very comprehensive review of the very important social determinants of health and how they'll fit into our Track 2 practices and how they'll be available for everyone, Track 1 or Track 2, to start thinking about and implementing this really important work for caring for our patients. So let me just bring you up to date on where we are with the program. As Chad said, 33 days until we launch this program. And we're still in the final stages of practice vetting. And as you know, participation is contingent on the final vetting and the document submission. The things that are still in process, even at this time, are program integrity screening and attribution and primary care taxonomy. We expect that this will be completed within the next week to 10 days. Fairly certain that that will happen. At that time, there will be notification by CMMI to all practices and to CTOs. With the notification, there will also be a group of documents that will come out. And importantly, those documents will need to be executed and returned by December 21st. I know that that is a very short period of time, but it's really important to get these in on time so that your participation can be guaranteed in program year 1. So practice documents and participation. In November, we released to the CTOs the CTO arrangement document. Those will be executed by the CTOs and sent to their subscribing practices when the notifications are done of which practices and CTOs are being offered program year 1 enrollment. There's also the CRISP participation agreement follow-up ongoing. There are a few practices that are still in process with those participation agreements. They need to be done before the end of the year and might as well get them done sooner rather than later. It is essential to get those done. You can't participate without being also a CRISP participant. In December, the CTO arrangement will be sent from the CTOs to the practices. Practices will have the opportunity to review those, sign off on those pieces of support that they want to get from the CTOs, and then send those electronically back to the CTOs and to our program management office. There will also be the very important practice participation agreements that will, and data worksheets that will come out to the practices and to the CTOs for review, and if you're in agreement, execution of those and return before the December 21st deadline to CMS. They can be returned electronically so that there's not the slow up of land-based mail, but they do need to be returned so that they can be processed before the first of the year by CMS. There'll be also in that same package that you receive with notification of entry into the program, there'll be registration for the Enterprise Policy Privacy Engine, which is basically the commitment to HIPAA, registration for the Enterprise Identity Management account, which says verifying who will be in the account and who will not. And then there'll be a registration to follow in December for access in January. The final deadline, again, is December 21st. Just as a reminder, in the CTO arrangement, it's a 2-page document that defines and confirms the relationship based on the practice option selection, so different arrangements for option 1 and option 2. It's effective in January 1st. It renews annually unless it's terminated by the parties. It describes the care management fee splitting between the parties, either 30 or 50%. of the fees going to the care transformation organization at the discretion of the practice. It describes the lead care manager requirement if there's a 50% share. It includes data sharing, discussions, and term and termination notifications. There's two appendices. One is the appendix that details exactly the services and staff offered by the CTO to all partner practices based on the option and track that they're in. The practices, of course, will initial and say which of those they want to select. That is, which services they want to select. The services will be the same for each CTO will have the same array of services for track 1, for option 1, and for track 2, for option 1, and correspondingly for option 2 for those tracks for all of the practices. Also, there will be Appendix B, which is the business associate agreement. This allows sharing of information between practices and their CTOs, and that business associate agreement is something that the practices and the CTOs will agree who originates that. Next slide. Some highlights of the participation agreements, just so that you understand what the participation agreements are going to be looking like in advance. The first is that the term is from 2019 to 2026. It's the entire program. It is a direct agreement with CMS. It's not an agreement with the state. This is a document generated by CMS, sent to practices and CTOs, and it will be returned to CMS directly. Termination, the practice may exit the program with proper notice. For the practice PAs, it provides access to claims and other data allowed through the PA. It will require the practices to notify beneficiaries of the practice's participation in a prescribed period of time. There'll be a form that can be placed on the practice's site to notify beneficiaries, and then an outreach either by paper or electronic to the beneficiaries to say, here's what the program is and some highlights of the advantages of being in Maryland Primary Care Program. It finalizes also the payment terms and outlines all the financial and performance reporting requirements. There will be additional details in the materials that are provided, both in the getting started materials from CMS early in the first quarter, and then later in the first quarter in the implementation guide that will have more granular details on the program, and those will be referred to in the PA. I want to point out that the PA is not a negotiable document. This is not a document that you can take back and say, I'd like to strike this or strike that, or can we talk about this or that. It is exactly what it is. It's a take it or leave it document from the federal government. Okay, and their timeline. The good news here is that we are at the end of our timeline, as Chad pointed out. It's nearly December. We have 33 days till launch. So all of the other portions of that arrow are now in our rear view mirror, and all we really have to do at this point is wait for either an acceptance letter with some more materials to execute, or a deferral letter. If there is a deferral letter, there will be some indication of the reasons for the practices being deferred. And if your practice is deferred for whatever reason, we look forward to working with you in the next year. There will be a new open enrollment period. We'll be probably opening that portal in the May to early June time frame for CTOs and then for practices, and we'll look forward to being able to see for any practices that are still interested in, they're not in the first program year, helping them get into the second program year. We're dedicated, committed to that. So we're near the end of that. I think this is our last slide, except for our information. Should you have any additional questions, then we'll open it up for questions online. And if I don't get a chance to say this to you again, wishing you the happiest and healthiest holidays, and hope that you find time for your families and your friends during this time, even as you're executing these documents. Alice, any questions?
Yes. So if you have questions, please go ahead and type them into the questions panel on the right-hand side of your screen, and we'll read them off as they come in. So our first question is, when do you expect CTOs will receive their final practice pairing lists?
We expect that'll happen by sometime around the end of next week or before.
So CTOs will get that will receive that letter with the pairing practices at the same time that the practices will also be confirmed of their participation in the program.
Okay. We have a question here from a CTO. Will a CTO receive a participation agreement with the CTO and CMS in early December?
Yeah, so when the list of practices comes out for the CTO, at the same time, both the CTOs and the practices will receive the final participation agreement, which will need to be executed by December 21st.
Get them electronic. These will come in an email electronically.
Next question, which measure are we responsible for that is directly related to social needs?
So a couple of things. There is the care delivery reporting, which will happen on a quarterly basis, and you will be asked if you're a Track 2 practice, how you are implementing social needs screening and resource directory addressing social needs. In addition, there is as I mentioned, connection on all measures, but specifically on the utilization measures for ED visits and hospitalizations per 1,000 attributed beneficiaries. How you treat patients' social needs will impact their utilization rates.
Thank you. If you happen to be deferred, what will be the term of the PA if admitted later?
The term of the PA then would be the beginning in the second program year, if you came in the second program year, through 2026.
Thank you. And follow-up question to that, what are the reasons for being deferred?
So there's several, as we understand it, several categories of deferral. One would be taxonomy, that is a practice does not have a provider who is designated by taxonomy by the MPPS as primary care as their primary specialty. Second would be insufficient attributed beneficiaries. And as a reminder, the attribution process that was used is a look-back process beginning in February of this year and then looking back for 2 years, prioritizing annual wellness visits or chronic care management codes, and then secondarily prioritizing plurality of visits. So there is possibility that new practices may not have a sufficient number of attributed patients, or others for one reason or another may have been at a patients that were at AWVs done in other places and didn't get attributed to them and didn't meet the hurdle. But attribution we think is probably going to be an issue. If attribution is an issue for your practice, we'll certainly encourage you to do annual wellness visits, which will put you right up to the top in the next attribution review. And then program integrity is another of the categories that programs would be excluded if there were issues related to federal government payments or some other issues with CMS in terms of program integrity, and then it failing to have the basic elements, electronic health records, or those kinds of things that would default to a practice.
Great, thank you. Our next question is, when will we have access to the new CRISP capabilities?
So the CRISP, as you know, has many capabilities today, and with the participation agreement with CRISP, practices can already be taking advantage of those. The newer capabilities that will be developed, including claims reports, will be made available starting when the program starts in January.
Our next question is from a CTO. Are there restrictions on how the PMPM is spent? What are the metrics that need to be achieved to qualify for the PBIP?
So there are restrictions on how the per beneficiary per month can be used on the care management fee. Those are spelled out in the participation agreement, and then I believe there's more clarification and future documentation that CMS will put out. In terms of the metrics, I think we have these updated in an FAQ that's on the MDH website, but briefly, there are 6 metrics. There are 3 clinical quality measures. 2 of them are diabetes outcomes control and hypertension control, and then there's a third one, which is initiation and engagement of treatment for substance use. There is the patient satisfaction survey, and then there are the 2 utilization measures, ED and hospitalizations per 1,000 attributed beneficiaries. In terms of the benchmarks and how that is calculated and where you'd have to fall and all that, that will all be released in a financial methodology document that should be coming out later this month. Excuse me, in December.
I think our next question is in relation to the CTO arrangement. So in Appendix A, there is a function to implement one alternative care strategy to give the patient more access to the practice. Can you tell us approved alternative care strategies to give the patient more access to the practice?
Certainly, there's a standard list of alternative care strategies, which would include group visits and home visits and telephonic visits. And then there's certainly the ability to be innovative and create other sorts of alternative visits. The important point being that care is provided without having it to be a direct individual face-to-face standard visit. That's where the flexibility occurs.
Our next question is, can you explain how CRISP will help with quality reporting?
So the quality reporting on the ECQMs is done on an annual basis, and it's done at the end of the program year. So quality reporting for the program won't be due until, I guess it would be January of 2020 for performance year 19. CRISP, all quality measures will be reported to CRISP. And CRISP has an existing tool that's built in and integrated for some EHRs called Caliper. For the practices that don't have EHRs that have that capability, they will make a manual portal entry available for all practices to submit measures. We'll be putting out more information on the quality reporting process during the year of 2019.
Thank you. Our next question is from a CTO again. If a CTO has 25 practices assigned, do we need to generate 25 CTO arrangement forms and have all 25 practices sign each CTO arrangement?
Yes, that's correct.
Thank you. We have a multi-part question here about NQF 004. This is in regards to the measure on initiation and engagement of alcohol and other drug dependence treatment. We do not currently receive alcohol and substance abuse claims from CMS as they are suppressed under shared savings. How can we calculate risk for these patients who have alcohol and drug abuse claims without looking at their history? Will the MDPCP program provide this data?
So we anticipate that we're certain that we will be working with practices to provide technical assistance to implement SBIRT, screening, brief intervention, referral to treatment, in the workflows and in the EHRs, so that information then would be directly embedded into the EHRs, and reporting would be done out of the practice's EHR in terms of that measure, just the same as it would be for the diabetes control and the hypertension control. But that will require implementation, and we will be providing during the course of the entire year technical assistance for that implementation.
Great, thank you. Are there penalties or otherwise for physicians who are not participating or who are deferred?
No, there's no penalties.
When will we know whether the 6 quality measures are final?
You will know because they'll be incorporated into the financial methodology and I believe the participation agreement in December. But we have also added those into the FAQs because, you know, under all communications to us, those are the final set of measures.
Just a follow-up question to that. Could you repeat what are the quality measures expected of physicians in the program?
Sure. So there are 6 measures total. There are 3 clinical quality measures: diabetes control, hypertension control, initiation and engagement of substance use treatment. All 3 of those are standard NQF measures. Then there is a patient satisfaction survey using CG CAPS that will be done by CMS and its contractor. And then there are 2 utilization measures: ED visits per 1,000 attributed beneficiaries and hospitalizations.
Okay. And we have a similar question here to one that's been asked before, but I'll read it off. For the alcohol substance use measure, how do you propose the providers measure that? Once we refer a patient for treatment, we will not be the ones treating them. Will this be tracked by CRISP?
So treatment, if a patient is referred for treatment, we should be tracking them. We should be able to get information back from whoever the treating party is, whether it's a co-located person in your office or someone who you have a referral relationship with on the outside. That would be the way that loop would be closed. It should be documented.
Thank you. Will the CRISP tool match rising risk patients with suggested interventions to prevent patients from moving into higher utilizer status?
So there is a tool that is being developed now, which is a risk stratification tool, be available, we anticipate, by the 3rd quarter of the first year, that will be displayed on CRISP, that will give this risk stratification and identify those who are the rising risk category.
Thank you.
In terms of matching them to interventions, that could be a future development. It's not part of the initial development.
I believe our next question is from the perspective of a CTO again. Does the lead care manager have to be assigned to each practice, or can they be split between practices?
So the lead care manager can be divided between practices. There just needs to fulfill the participation agreements stated ratio. And I believe that is 1 to 2,000 fee-for-service beneficiaries.
Do practices have to pay for CAPS?
No, practices don't pay for CAPS.
Another follow-up question on NQF 004. The question others are trying to ask is, will CRISP give practices data on patients diagnosed with alcohol/drug dependency occurring outside the walls of primary care, such as behavioral health facilities, etc.?
I can't give you a final answer on that. I believe the answer, to my understanding, is no. The CRISP, without getting specific share ability from the patient to share that information, that they are not permitted under 45 CFR Part 2 to share that the CRISP is not permitted to share that data. However, providers who are caring for the same patient are free to share that data. So it doesn't need to go through CRISP. It can go directly from provider to provider.
Can a practice provide our own case manager, or does it have to be with the CTO?
The practice can certainly provide their own care manager.
And are there any credentialing requirements for the case manager?
The case manager, care management staff need to be someone who has a clinical license or certificate, but it could be any kind of clinical license or certificate.
If there are more questions, we welcome them. Otherwise, we will finish up here in a few minutes. All right. Do we have more questions, Alice?
Yes, we had a few more just come in. Are CTOs required to spend half their CMF on clinical care?
CTOs are required to spend at least half of their care management fee on care management personnel for the practice. Okay. See if we have any other questions. Oh, a few more coming in. We really appreciate the questions because they're quite helpful, I think, for everyone on the line. They're quite helpful for us as well.
And the question is?
So we have a long question here about a CCLF data feed. We were told in earlier webinars that we could request CCLF data from CMS for our patients under MDPCP. However, the answer we received from CMS is a little different. CMS's response indicated that because we are receiving data for the patients under current MSSP ACO agreements, we would not be receiving data for MDPCP patients. It looks like we may continue to receive the data for existing patients, but once our TINs switch to MDPCP practice TINs, we are not likely to receive data for new patients. How can this gap be addressed?
Yeah, I think that's a very complicated issue, not one that's in our direct control in any way, shape, or form. I know for certain that practices will receive information about their patients from CMS upon their request through CRISP, and that CTOs will also receive the same aggregated reports for each of their related to each of their individual practices about all of those patients. Reports that are generated by data that is provided from CMS to the practices to CRISP, and then CRISP will make those reports available both to practices and CTOs. The remainder of the complexity in terms of how other data would be shared is something that will have to be resolved in the future.
Thank you. Question here, could you revisit the CTO PBPM?
Sure. So not sure what the specifics are of that, but generally CTO has two mechanisms for being paid. One is if it has partner practices, receiving a PBPM split for the care management fee, and that's either a 50 or 30% split that it was received, with the rest of it going to the practice. All of those monies are coming directly from Medicare. The other thing is that the CTO will separately from the practice receive a PBPM for the performance-based incentive payment. And depending on the track of its partner practices, it's either $250 per beneficiary per month or $4.
Thank you. Is the social determinants of health screening required for all tracks?
No, it is required for track 2, but we highly encourage it for all tracks. I think many practices that we have talked to that are in track 1 are thinking about or have already put this into their workflows.
Thank you. We have two very similar questions here about care manager credentialing. So can the care manager be a community health worker or a medical assistant?
So licensed or certified medical assistant would be acceptable. Community health workers currently are not certified or licensed in the state. I believe that there's an anticipation that they will be based on recent statute. So once that occurs, it could qualify them also as capable to be care managers. So,
and just to add to that, community health workers can be part of the care management team, and we highly encourage it. They just couldn't serve as the lead care manager. And that is a requirement when a practice is working with the CTO. Is not a requirement. There's no lead care manager requirement when a practice is not working with the CTO.
Question about staffing. Is it okay to contract those personnel?
Yes, it's perfectly okay to contract.
Does a nurse have to sign off on the care plan?
There's no, to my knowledge, there's no requirement to sign off on a care plan. The requirement is to have a care plan and have it in the electronic health record. Most documents are electronically signed in an EHR in any event.
When the practice agreements are being signed, the BAA agreement is referenced. Will the MDPCP program provide us the BAA, or do we as the CTO originate a BAA for the practice?
Yes, it would be either the CTO or the practice to originate the BAA.
Since MDPCP payments are counted as costs, will practices participating in a Medicare MSSP ACO be eligible for PBPM payments?
No. If they're in an MSSP ACO, they would get shared savings from their ACO, but they would not be participating in the PBIP.
Right, so they won't be eligible for the PBIP because of the shared savings. They are eligible and will receive care management fees.
And if they're in Track 2, comprehensive primary care payments.
Question going back to community health workers. Does this mean that community health workers don't qualify as part of the funds that the CTO has to spend on the care team?
No, does not at all mean that. We really value the community health workers. The only prohibition would be that the care manager or lead care manager needs to be a licensed or certified clinical person, so that until such time as they are licensed or certified, they wouldn't qualify.
Are there any mandatory elements in the care plan, such as a frequency requirement?
No, just the frequency would be established by the needs of the patient, and some patients may need to get more frequent, some less frequent, some will fall out of the need to care plan altogether.
Good. Well, we'll wait another minute here. There's a lot of great questions. We'll see if there's any more, and then we'll hopefully give you some time back.
I want to thank you all for your participation tonight. This was, again, wonderful. We look forward to talking to you again next Thursday. We'll continue this process and these webinars. We find them valuable. I hope you do also. And again, the beginning of the holiday season, wish you all the best. Have a good night.